Hello, good morning, everyone. I am Dr. Banshi Saboo, currently Secretary for Diabetes India. It's my great pleasure that today we have a webinar with American Diabetic Association. What we have learned, it's learnings from American Diabetic Association. We were part of one global obesity care program. I was speaker for that, and Dr. Victoria was sharing. We have today three eminent speakers, Dr. Victoria, Dr. Sevi, who is part of board member of the Obesity Society and very active member of American Diabetic Association, and Dr. Mohamed Hassanein from Middle East, from UAE, Dubai. I'm thankful to Lupin and all the delegates who are joining today. More than 3,000 delegates from India who are participating in this meeting, who are registered. And we are thanking particularly US speaker because for them it's a Saturday late evening and it's a Sunday morning for India. So good morning for all Indian delegates and participants, and it will be late good evening for Victoria and for Sebi. Dr. Mohamed Hasnain just informed me that he'll be joining soon. It's my great pleasure. Today we have with us Dr. S.R. Aravind, who is currently president of Diabetes India from Bangalore. I'm sure everyone knows him, Dr. S.R. Aravind. I will be requesting him to formally welcome our international speaker and our national speakers along with our delegates. So over to Dr. S.R. Aravind for your comments.
Thank you, Dr. Banshi, and a good morning to all the viewers across India, and then a good evening to those who are actually in the US. Thank you so very much, Victoria. Thank you, Sabyasachi, and thank you, Mohamed Hasnain, for having taken time off to be with all of us today. And it's going to be a great online conference, basically translating what was discussed at the New Orleans, something that's more relevant to what the Indians are looking for. And then we have been seniors like Makkar and so many others who have been practicing obesity management for a very long time. And the great work is being done by Dr. Banshi, Amit, and Vipul. I would like to also thank Lupin Pharmaceuticals for having made this possible in association with Diabetes India. I will not take too much of your time. I think with this, I'll close my remarks. Welcome all of you. Let's have a great time listening to all the great speakers. And we'll be enriched with a lot of knowledge on how to manage obesity across Asians and Indians in particular. Over to you, Banshi.
Thank you. So you know that American Diabetic Association, since last 2 years, they have already started Obesity Association. Victoria is heading it, Obesity Association, and you can see her on her photo also, the left side, Obesity Association. And me and Makkar are part of this global initiative of American Diabetic Association too. And we were part of this meeting in American Diabetic Association with particularly that symposia. So now I request Dr. Vipul to introduce our speaker, and then we introduce. After first talk, we can have a few questions, but at the end, we will have panel discussion, which will be moderated by Dr. Makkar. Over to Dr. Vipul.
Thank you so much, Bansi sir, for kind introduction. Thank you so much, all of you, to join Sunday morning for India and late evening and Saturday in USA. It's my privilege to welcome you all to ADA 2026 Decoded, an important academic initiative for Diabetes India, Impact 365. We all know every year American Diabetic Association scientific sessions redefine the future of diabetes as well as obesity care across the globe. However, the real challenges lies not only in understanding the science but also to apply that science to the relevant population across the globe. Today's program has been thoughtfully designed and planned to bridge that gap by my mentor, Dr. Banshi Saboo sir, of course. So we are honored to have us an international faculty. And to start with first talk, I would like to call Dr. Victoria. I would request tech team to show her CV. So Dr. Victoria is a resident internal medicine, Loyola University Medical Center, USA. She has a fellowship of endocrinology, diabetes, and metabolism from Washington University School of Medicine, St. Louis, USA. She is founder and CEO of Paris Wellness and Diabetes Center, USA. And most important thing is she is a triple board certified in endocrinology, obesity medicine, and lifestyle medicine. She's a member of National Committee, American Diabetic Association, board member, Diabetic Sister USA, international faculty and speaker with expertise in diabetes, obesity, and lifestyle medicine. Special interest in diabetes, obesity, cardiometabolic health, and preventive medicine, and recognized leader in evidence-based lifestyle intervention and metabolic disease management. We are honored to have you here, ma'am. Over to you.
Thank you so much. And I'll have to circle back to you all and also say thank you for the collaboration, the partnership, and everything that you all did also at the American Diabetes Association. We definitely do appreciate that. All right, so I'm going to share my screen, and please let me know if you see it. All right, so yeah, thank you again for the warm welcome. I do not have any disclosures to report today. And what I want to do today, as already discussed, is really share some of the key findings and key teachings that we did at the ADA Scientific Conference at New Orleans, and we'll describe the global obesity epidemiology, some of the impact that obesity has when it comes to cardiometabolic health, identify some key drivers of obesity, as well as evidence-based management strategies, and then emerging future direction when it comes to obesity care. One thing that I would like to emphasize, and this was emphasized a lot throughout the scientific conference, is that obesity is a chronic disease. And, unfortunately, we hear many things from many places that is not treated as such. Globally, we're still in the process of making efforts to make sure that people recognize it as a chronic disease, just like you would with diabetes, hypertension, COPD, etc. It is also important to realize that it is relapsing as well as progressive. So we really need that intentionality, that understanding that this is chronic. It can relapse, is also progressive. And keeping that in the back of our minds help us to understand how we approach obesity, not only as a provider, but as a healthcare system. The interesting thing about the space of obesity is that the science has evolved. We know that obesity is regulated by this interconnected hormonal network, and it's not willpower alone. In the past, there used to be the stigma that this is all lifestyle and all willpower. But we know that there's a hormonal dysfunction, and there is this constant communication between the different hormones, and that's GLP-1, GIP, leptin, ghrelin, insulin. There's a lot of hormones, and this interconnectivity from the brain, GI tract, pancreas, adipose tissue, and all of them are in constant communication. And they're signaling hunger, satiety, how much nutrients to take in, energy stores. And there's an integrated signal that goes to the hypothalamus, and that signal really regulates the homeostatic, so that's the energy regulation, as well as the hedonic, which is the brain reward pathway. So when we think about the treatment of obesity, we have to realize that we're treating all these different hormonal dysregulations, as well as these different pathways and the reward system that comes with eating. And taking this into account helps you realize that when I mentioned the chronicity of obesity, when you lose weight, there's also an activated compensatory mechanism that the body tries to get you back to that highest weight. And all these are complicating factors when we think about the treatment of obesity, as well as the long-term maintenance once there's weight loss. We do know that globally, more than 1 billion people are diagnosed with obesity. And this represents about 13% of the global population. Unfortunately, the obesity rates have tripled since 1975. And the expectation is that this will continue to increase. By 2035, there will be a 1.9 billion adults globally living with obesity. And by 2050, 3.8 billion adults are projected to live with overweight and obesity. And that's more than half of the world's adult population affected. Now, we do have more than obesity medications. As we all know, the GLP-1 space has come and it has revolutionized the way in which we treat obesity. However, we're not seeing globally a measurable impact when it comes to the prevalence. So again, and this has multiple reasons, from limited access of appropriate treatments, the high cost of treatment, treatment discontinuation that we know can be extremely high, more than 50% at year one. So these are certain major barriers that prevents us from really seeing a huge trajectory in a positive direction when it comes to the overcoming the obesity epidemic. One of the major misconceptions, and this is one of the things I'll stress at scientific sessions, is the fact that there are multiple causes of obesity. And this is from the biology, genetics, and hormonal regulatory problems that I mentioned earlier. In addition to medical conditions, and I'll talk about our standards of care that came out a day before or the day of scientific sessions. There's also environmental factors that shape obesity. So you think about urbanization of different regions globally, physical activity opportunities, and the fact that globally there's a lot of physical inactivity. And then, of course, ultra-processed foods, and that's something that was talked about a lot during the global panel, how these ultra-processed foods are affecting people living with obesity, both causing it and also preventing the successful treatment of obesity. And then you think about the social and psychological factors when it comes to obesity, from education, culture, stress, mental health, sleep. All these are factors that really affect and cause obesity, and things that we as practitioners always have to keep in the back of our mind. It's not simple. It truly is a multifactorial cause when it comes to overweight and obesity. I talked about the highly processed foods. Again, something that we have to be intentional. This is not something that we're not only seeing in the United States, it's seen globally. As foods become more highly processed, the quality decreases. We had a nutrition panel during the scientific sessions that talked about this. These ultra-processed foods tend to be lower in fiber and micronutrients, and they tend to be more energy dense and highly palatable. And the fact that it's highly palatable means that it promotes excess calorie intake. And all of this contributes to obesity, from driving insulin resistance, inflammation, hypertension, dyslipidemia, and then ultimately increases cardiometabolic risk. So if you think about the health impacts of obesity, obesity in itself affects nearly every single organ system. And this is very important because, again, later on, we'll talk about screening and diagnosis and some the guidelines that was released at the beginning of scientific sessions, because we have to think about what is obesity or overweight doing to the individual. Are there obesity-associated cardiometabolic disease or complications such as type 2 diabetes, cardiovascular disease? Is there sleep apnea? Is there liver disease? Arthritis, CKD, etc. So we have to look at things beyond the number. It's also important to realize that obesity has an impact on mental health. Obesity and depression are actually bidirectional, and people living with obesity have up to 55% higher risk of depression, while people with depression also have about 58% higher risk of obesity. So keeping all these things into consideration when we're thinking about how we're going to treat and approach people living with obesity. So when it comes to the screening, we have to understand that for a very long time, of course, as we know, we've been using the BMI as a screening tool and even one for diagnosis. And there are inherent flaws when it comes to the use of the BMI. A BMI more than 30 is highly specific for excess adiposity, and the specificity is about 95% or higher. So when a BMI identifies obesity, it is usually correct. So therefore, there are very few false positives. However, the limitation is in the sensitivity. A BMI greater than 30 has a sensitivity of about 50%. So in other words, that means that the BMI alone misses many people with excess adiposity, especially those with central or visual adiposity, which we know ties directly to cardiometabolic risk factors. So the BMI by itself cannot distinguish between fat mass from lean mass, nor can it distinguish what visceral adiposity that patient has. So it's very important that we do something above and beyond BMI. And one thing that I'll talk about later is really the use of this anthropometric measurements, such as waist circumference and waist to height ratio, which will help us to improve our cardiometabolic risk assessments. The waist to height ratio is particularly useful because it's one of the strongest simple anthropometric indicators of cardiometabolic risk, especially those in the Asian and South Asian populations where diabetes, insulin resistance, and liver disease, etc., actually occur at a lower BMI threshold. The 2026 newest chapter of the Obesity Association Standards of Care was released the day of scientific sessions. And this was a chapter on screening, diagnosis, evaluation, and staging of adults living with obesity. And the key thing that we added was the use of these anthropometric measurements to BMI. As I mentioned, BMI by itself is just not enough. We have to have measures of visceral adiposity. So what did we do? We said that now for those with now we'll just use, for simplicity's sake, Asian background. We've lowered the threshold when it comes to diagnosis of obesity. So obesity can be diagnosed with a BMI of greater than 27.5, but also if you have a BMI of 23 through 27.4, but a higher visceral adiposity, meaning a waist to height ratio of more than 0.5, or a waist circumference that's elevated, greater than 80 for women and greater than 90 for men. And then overweight is a BMI of 23 to 27.4 without elevated central adiposity. So what we did is that, again, we realized that the BMI by itself has its inherent flaws, and we have to use these anthropometric measurements of visceral adiposity. And if you have enough visceral adiposity, then with a lower threshold of a BMI, that can give you a diagnosis of obesity. And also, the standards of care chapter that was recently released emphasized the use of staging, and then we use the Edmonton staging criteria. And what this does is it really, again, looks further than that BMI, even looks further than the visceral adiposity. It looks at the obesity-related disease and complications. It looks at physical symptoms. It looks at psychological symptoms as well as physical limitations. And what it tells us is that when we're thinking about treatment, it's not a one-size-fits-all approach. We have to think about both that visceral adiposity and also what is the condition or the adiposity doing to the patient. Is there obesity-related disease? Is there physical symptoms? Is there psychological or mental or functional limitations? And all these are going to help us when it comes to the treatments and care of those living with obesity. The care is comprehensive, right? So I mentioned that at the very beginning, that obesity by itself is complex. So we have to think about a very holistic picture when we're treating those living with obesity. So the first thing I have here is that individual patient-centered care. And this really means that we are focusing on the individualized patient sitting in front of us, though the person who and I mentioned this, we can't have a one size fits all. So we think about their complications, we think about social determinants of health, we think about cultural preferences, we think about their specific access barriers, their specific treatment preferences. Do they want oral medications? Do they want injections? Do they have a needle phobia? What has worked for them in the past? What have they tried in the past? What stress are they going through? So again, having that individualized treatment when it comes to the care. Language is also very important, and we emphasize in our standards of care a person first, non-judgmental language. So that really means saying things like a person living with obesity. And the same applies with diabetes, person living with diabetes, person with obesity. We would not want to say or call somebody just obese or morbidly obese. We would not want to use non-compliance. We would not want to use failed treatment or weight loss failure, because that puts that stigma and bias to the patient. We have to recognize that this is a disease, one that they can struggle with, and one that they have a history of stigma and bias that we have to be very cognizant of, and always have a trauma-informed care mindset when we approach those living with obesity. It's also important that we look at or we discuss healthy nutrition, physical activity, behavioral therapy, and this comprises of self-monitoring skills, goal setting, problem solving, motivational interviewing, as well as relapse prevention. We use SMART goals, and we also have to realize that sometimes things can happen, and they can go from different stages of change, and that's okay. We just have to be supportive throughout their journey when it comes to obesity treatment. And of course, obesity medications, and that has, of course, revolutionized over the years. Metabolic and bariatric surgery, long-term follow-up. Remember I said this is a chronic disease that needs chronic and long-term support. And then, of course, population health strategies. We want to think about what can be done when it comes to prevention, school systems, environment, food policies, healthcare systems. So all the management of obesity has to be comprehensive and holistic when it comes to their approach. When it comes to the pharmacological treatment of obesity, and this is something that we touched on thoroughly during the scientific sessions, it's always important to realize that though the incretin-based therapies are the latest and actually have a very robust weight loss, there are multiple options that you always have to take into account. So the versatility of the obesity medications should always be in the back of your mind. And the selection is going to be based on different factors, which we'll talk about soon, but be mindful of what the goal is, and that even a 5% reduction leads to metabolic health benefits. You're going to see, if it's more than 10%, those improvements in obesity-related complications, and then above 15% is really where you see that maximum benefit. We talked about retatrutide, which just completed phase 3 clinical trials, which has shown robust weight loss up to 30%, which is something that we haven't seen when it comes to medication. So just always remember that we have a variety of medications that you can choose from that should be tailored to the individual in front of you living with obesity. We had our standards of care presentation. The pharmacological chapter was released in February of 2026. And this talked about when it comes to the selection of the obesity medications, we have to think about, again, what is the presenting symptoms and signs of the person living with obesity. Is there obesity-related complications or not? And if there is no obesity-related disease or complications, then we think about promotion of weight reduction. We think about prevention of progression of obesity. And then we also think about the reducing the risk of developing obesity-related disease and complications. So if you have someone that you want about a 10% reduction in weight, then you think about the incretin therapy, semaglutide, tirzepatide. If you want a modest, less than 5%, then you know you have your naltrexone, bupropion, you have your liraglutide and phentermine, etc. So again, tailoring the goals that are shared decisions between you and the patient to the treatment option. If there are obesity-related diseases or complications, then that changes. We want to tailor the treatment based on those disease-related states that we want to improve. So, for example, if somebody has established cardiovascular disease, we know from the SELECT trial that semaglutide reduced cardiovascular events by about 20%. Therefore, that will be a great choice when it comes to treatment. We know that from the STEP-HFpEF trial that semaglutide improved symptoms and functional status in those living with obesity-related heart failure. So therefore, you will select semaglutide for heart failure. So the pharmacological chapter of standards of care really helps you to identify which treatment options are best depending on the obesity-related diseases and complications. And then when it comes to the barriers of treatment, there are multiple reasons why there are that the treatments can be stalled. And that can range from lack of political will, interest in actions, lack of training of healthcare providers, high out-of-pocket costs, as well as obesity itself being recognized as a disease. This work is from the MAPS-1 from World Obesity Federation that was published in 2019, and they're actually in the process of doing another survey with new results that they're currently evaluating and hopefully will be published soon. And then we always have to think about stigma. And that's something that should always be in the back of your mind, because there are different ways in which stigma can present itself. You can have institutional healthcare system stigma, and this can be seen in discriminatory policies, lack of appropriate chairs and gowns and scales that are not in a private room, exam tables. You can have interpersonal stigma, and this can be the way that we communicate with people living with overweight and obesity. And that's, putting blame, using disrespectful communication, assuming symptoms are automatically due to the weight, and providing different types of care just because of obesity. And then intrapersonal stigma. So this is really stigma and bias that have been internalized from years of living with obesity. We do know that those living with obesity, those who had childhood obesity, experience bullying and trauma and harassment, etc. So they also come with this internalized sensitivity and expected judgment. And that's something, again, that we have to be very cognizant of when we are treating those living with obesity. The 2026 Screening Standards of Care also talks about the intentionality when it comes to the evaluation and treatment, and really saying that we can't treat obesity as an afterthought or addressing it when there's a little bit of time left in the visit. Wherever you are, whatever healthcare system, whatever clinic you in, you really try to have some type of clinical workflow that allows you to have time to have a thorough evaluation, assessment, and treatment, and follow-up when it comes to obesity. The standards of care has created this care pathway, and really it centers around education of the healthcare professional, making sure that they're prepared, creating some type of entry point for the assessment of a weight-focused visit just for obesity, using some type of efficient care process, work for a care process. Who is going to do your anthropometric measurements? Is there going to have an established staff member that's been trained to know how to do it, that can make it more efficient when it comes to the optimization before the provider comes in to see the patient? And then, of course, having a shared decision-making approach for long-term care when it comes to treating those living with obesity. The future direction is very exciting. We've moved beyond the dual agonists that we're used to phase 3 trials, as I mentioned, with triple as well as investigational quadruple agonists. And all of this, we're looking at improving the goal of efficiency, tolerability, overall cardiometabolic health while preserving lean body mass. We're looking at precision medicine when it comes to obesity care. How can it be more personalized? Looking at obesity phenotypes, comorbidities, genetics, patient preference. We're looking at how can we diagnose and intervene earlier. And of course, when it comes to the implementation of these guidelines, how can we do it in a way that's realistic and practical? And then globally, how can we have equitable global access to obesity care? So I'm going to end my talk by saying that obesity is a growing global epidemic that requires coordinated action across government, health systems, clinicians, communities, and individuals to prevent, expand access to treatment, and reduce obesity-related complications. And truly, when it comes to changing the trajectory of obesity, it will take all of us. Thank you.
Thank you so much, Victoria, for this wonderful talk. And at the late night is on Saturday, so we are very happy and we are thankful to it. Though we have question and answer at the end of the session, I would like to ask one question: that which public health intervention has shown the greatest impact in preventing obesity so far in the population?
Yeah, that's a very good question. I will start with education, and that is both the providers as well as empowerment of those living with obesity. And when I talk about education, it's both the treatment, but also I talked about stigma, right? We have to start the conversation. How can we even get people in the door? We do know that people living obesity, less than 10% seek treatment. That's not good. So really getting the word out that this is a chronic disease, nothing to be ashamed about, making sure that we provide a place that's comfortable, psychological safety for them to come and talk to us, both for the provider and for the patient living with obesity.
Thank you. Thank you so much. If
You're
any comment by
welcome.
Dr. Makkar sir or Purvi ma'am.
No, I think, Victoria, your presentation covered a lot of very important points. We think that in India, recognition of disease, obesity as a disease is very, very poor. But I'm surprised that, your presentation showed that it is still a challenge even in US, both at the level of providers as well as those living with obesity and the population at large. So, in our discussions earlier in the roundtables and otherwise, we have always, come up with the education as the key to taking care of all these challenges. So I think that was very nicely highlighted. And uh, the the obesity management guidelines that have come up in February end are very important document. I think if people are going to follow this, that will help a great deal in improving obesity care globally.
Thank you. Thank you so much.
If I may,
Victoria.
just a quick comment. Actually, it was a fantastic presentation, and I think it was a very, very elaborate and pointed discussion on the guidelines. So thank you for that, Victoria. I just, we know that childhood obesity and adolescent obesity is a very, very massive problem world over. Your quick thoughts on this existing issue in the US?
Yeah, excellent question. I think, the two things. Number one, prevention, right? How can we prevent? And that's really starting early. I talked about the obesogenic environment that we're currently in and the ultra-processed foods. There is a healthcare system, but there's also a food policy. How can we start talking about the foods that our children are eating? What occurs at school? How can we start having conversations where even school nurses or people at school can also help with identifying and supporting children living with obesity? How can we increase physical activity, making that more accessible to children, both in school and out of school? So the food, the environment, and then education of the family. When a child is living with obesity, it should not just be a problem for the child, but we have to bring everybody to the table with really comprehensive, robust intervention, with behavioral modification as well as medication at that time if needed. So a holistic picture from government policies where we can really change some of the environment that we're currently in, to the providers, making them comfortable approaching it, schools, at the clinic, as well as parents, in a way where it's sensitive and it won't traumatize the child. And then finally, the child itself, and how we can do it in a way that they feel safe to talk about it, and also in a way that it's efficient and practical for them.
Fantastic. Thank you.
Dr.
You're
Amit, want
welcome.
to add something?
Yeah, excellent presentation, Victoria. I just wanted to ask one thing, and there was a recent paper which actually says that different regions of the world, they are actually at different phases when it comes to obesity. And when it comes to US and Canada and probably Japan, the obesity rates are now stabilizing. And probably the prevalence is not increasing anymore, but it is not even decreasing. But for countries like regions like Asia, Africa, it is rises exponential. So I think when we design systems and interventions, probably we need to think which trajectory a country is in, and accordingly we need to modify. So any thoughts on that?
Yeah, and I know the papers I'm referring to, Dr. Gupta, is interesting because it's hard to really show that it's correlating to what is correlating to, or if these trajectories are actually something that's sustainable. We're hoping so. What we do know is that the new medication, the interventions, may or may not have played a part in that. We saw that stabilization in 2022 and slight decline in 2023. We're not seeing that globally, as you pointed out. I will say, if you think about accessibility here in the States and in Canada, here in the States particularly, we do know that the accessibility of some of the medications tend to be one of the highest compared to other countries where obesity, number one, may not even be recognized as a chronic disease, or even if it is, the treatments, they may not have the effective, robust treatments that some other countries may have access to. I completely agree with you. Just as I emphasized that individuals have to be intentional with the person in front of you. The countries also have to have that intentionality. We have to focus the treatment and the solutions to make it country specific. What works for me? There are some solutions that can hold globally, but some that cannot. You have to factor what is the reimbursements and the payer system looks like. All those things take into account. So I think, lessons learned from different countries is always helpful. The conversation is always helpful. And then we take it back to our countries and see what's going on. Lessons learned that will work well in the country, then we implement. And then there might have to be some tweaks here and there to make it country specific for that particular country to move the needle.
Thank you, Victoria, for sharing your expertise as well as your time. And on a Saturday evening, we are bothering all of you, but we really gained a lot. So thank you for joining in. And with that, it's a great honor and pleasure to invite our next speaker for this program, ADA 2026 Decoded. And it's a real pleasure to invite Dr. Sabyasachi Sen, who is a consultant endocrinologist specializing in diabetes, endocrinology, and metabolism, a board member of Obesity Society, faculty at the George Washington University Medical Faculty Associates, USA, and a consultant in the Washington, D.C. Veterans Affairs Medical Center. Has over 35 years of clinical, academic, and research experience in endocrinology, has been an investigator for several international global studies, and is very widely published as well, an international faculty speaker on metabolic disorders, and his special interests include type 2 diabetes, obesity, metabolic disorders, and diabetic kidney disease. Without much ado, let's have Dr. Sabyasachi Sen take the floor.
Thanks, Purvi, for the kind introduction. I'll try to share my slides. Thank you so much for inviting me for this talk. I don't want to represent any specific society or association, so this is going to be a purely educational talk. And I thought that, yes, I'm going to give a Western perspective, but I also wanted to highlight the things I learned from the ADA and a focus from my perspective or US perspective on pharmacotherapies. This is the talk that me and the fellows prepared for George Washington University. So hopefully this will help the Indian community as well. So in ADA, there was a lot of focus, not just on diabetes, but on obesity, because as you all know, the obesity per se is moved from weight management cardiometabolic disease to a cardiometabolic disease modification. So as diabetes has moved from glycemic control to more weight management, similarly, obesity management has moved from weight management to more complication management as well. And we, throughout the world, are looking for more data on so-called disease process management, whether it's a cardiometabolic or MASLD. So this is a little bit busy slide, but on a broad perspective, what did we learn from ADA per se? We learned that the cardiorenal risk as a primary goal, and essentially to focus a status of complications beyond glycemic control, or at least at an equal status of glycemic control. So both the cardiovascular and kidney risk reduction is important to look at beyond just glucose management. So hopefully when you are seeing your patients, these criteria are there in front of you as well beyond A1C control. How do you define the diabetes management success? So the success was essentially, it was heavily scrutinized, the use of BMI, which we tend to use as a universal measure of obesity, to move on more broadly accepted values such as waist circumference and towards more precision medicine and individualized social determinants of health and body composition rather than broad population averages. The other major aspect was the use of diabetes technology or use of automated insulin delivery systems. And we had shied away from using this technology from aging population. So I think that population, and as per as ADA, needs to be more in focus. I know there is more aging population in India and also in US. So I think this needs to be kept in mind. And the closing the so-called DSMES gaps, which is essentially, despite the technological leaps, there's a significant disparity in care, access, and patient education, as Victoria just mentioned, that there is still ways to go for the disparity management or address the disparities. And that's not just for United States, that's also true for India and worldwide. And ultimately, the last point that I would like to make is to transition to cellular and genetic cures. This is actually important not just for insulin cell therapies and other immunotherapies that are currently available and are coming in more, not just for diabetes management, but also lipid management, where there is more so-called biologics and immunotherapies coming in. So one needs to be cognizant of the fact that there needs to be more broadened clinical trial eligibility requirements, more cross-nation collaboration, which I'm trying to build up with India as well. And lastly, the new pharmacotherapies. And I wanted to highlight some of the new pharmacotherapies that was discussed in ADA. I know Victoria mentioned about a few of them, but I wanted to go a little bit deeper into it. So as you know, the incretin evolution has moved from GLP-1 to dual agonist to triple agonist to combination therapies. And this has happened fairly fast in going back to 2015, when exenatide was almost the only therapy, and subsequently we have dual and triple therapies and combination therapies coming in. One is retatrutide, which is from Eli Lilly, which has demonstrated, as you just heard, about 30% weight reduction. There is significant weight loss efficacy. And these are some of the numbers from various trials, which is primarily looked at 80 weeks and 104 weeks. This was essentially a Transcend trial. We have the Trump trial as well, but remember there is some common side effects which are common between all of these therapies, which are primarily gastrointestinal, such as nausea and constipation, and other safety profiles needs to be borne out. It's not yet available for prescription, but hopefully will be available by 2027. What is the drug? It's essentially triple agonist, which is GLP, GIP, and the glucagon agonist. Then the other drug that was looked at was CagriSema, which is from Novo Nordisk, which is a combination of amylin and GLP-1 combination. And again, hopefully a decision from FDA will come in by late 2026, when we can hopefully try to use this drug. But remember, it actually narrowly missed a non-inferiority endpoints against retatrutide and others. And I'll show the comparison between various drugs a little bit later. Busy slide, but remember the main idea was that CagriSema did not seem to meet the main primary endpoint of showing non-inferiority. However, compared to tirzepatide and others, but did show approximately 20.2% weight reduction in some secondary treatment regimens. There are still ongoing trials, as I was mentioning, for cardiovascular and secondary benefits, and some inflammatory markers. The other one was survodutide. This is, I think, an important drug which specifically focused on MASLD, or metabolically dysfunction associated steatotic liver disease, which used to be called the fatty liver disease, or non-alcoholic fatty liver disease. We moved away from those terms to MASLD. This is essentially a dual agonist of glucagon receptor and GLP-1, which is developed by Boehringer. So this particular medication, the main mechanism is by activating the glucagon receptors, and is specifically designed to increase energy expenditure and reduce appetite together, which distinguishes from the other traditional GLP-1s. I think this drug specifically looked at so-called MASLD as a complication of diabetes and obesity. Like any other medications in this paradigm, nausea, vomiting, and diarrhea are there, which obviously needs to be borne out with further trials. The other one was Maritide. This is a GIP, essentially activates GLP-1 and also blocks the GIP receptor to improve fat regulation. So it's a GIP antagonist, so it's a combination. So this is a new molecule that is going to be used. It's a combination molecule. So keep in mind that this is also in the pipeline. This is a little bit behind the other that I just showed a few minutes back, but this is coming in the pipeline as we speak. The weight reduction is a little bit less compared to the others. This is also remember, these are all injectables. This one particularly has about 16% weight reduction at about 52 weeks. Orforglipron, which is an oral agent, unlike the injectable agent, this is an oral pill. It's a non-peptide small molecule that doesn't require the fasting or the other restrictions for Wegovy, which I'm going to show the next. Weight loss in about 72-week study showed about 11.1%. So as you can see, it's a little less than the injectables. But the main advantage is that you don't have to counsel patients about the time of taking the medication or the waiting before eating and all those other counselings that you need to do with Wegovy. So we are hopeful to get more information about this trial. The target dose is 17.2 milligrams, but that will be gradually gone up over a period of time. Remember, you should not be crushing these tablets, as that will break the so-called the small molecule peptide activity. The other main oral incretins that it seems India has been using more than United States is semaglutide, and it does have some strict guidelines how you can increase the absorption of this medication. You need to wait at least 30 minutes before you eat or drink or take any other medication, and you need to take it first thing in the morning on an empty stomach. And that has some issues with some of our obesity patients, so keep that in mind. It does show an average weight loss of about 13%, which is very similar to orforglipron that I just showed before this one. There are several other medications coming in. I'm not going to dwell too much about it. I specifically wanted to talk about the MASL because, as you know, this disorder has reached quite significant proportions in the United States and India, and also the Middle East. Approximately 1 in 4 patients with diabetes seems to have MASL, so that's a significant population that we are talking about. These are some of the newer agents. Maybe you already know about it. It's FGF21 analogs and the oral PPAR gamma, PPAR alpha, and a delta agonist that is also being looked into for MASL. GLP, GIP polyagonist that we also talked about. And more importantly, there are 2 drugs, as you know, are currently approved in United States for this indication. One is resmetirom, which is a thyroid beta receptor agonist. The other one being semaglutide, but there was quite a few seminars and talks on use of combination of these medications, GLP, GIP, or other oral agents, even with resmetirom as a possible therapy for MASL. So here you have a cross-company kind of comparison of weight loss of different medications. You have orforglipron, at about 11 to 15%, survodutide close to 20%, maritide also fairly close to survodutide, CagriSema is a little bit better at about 23%, and retatrutide about 30%. These are the various mechanisms that I also just talked about. This is to summarize what I just said. And of course, the coverage, affordability, and utilization management is important. As I just mentioned, this is one of the main kind of barriers that we still have for delivery of obesity and diabetes management. So one needs to still counsel patients regarding the side effects of these medications. Remember, it does cause gastroparesis to a certain extent, or reduces gastric transit time. So that might be problematic for some patients. To counseling is important before you start this patient. The other aspect that was fairly discussed quite widely was muscle preservation when you use these medications. So to monitor it and then to implement various strategies to prevent the muscle loss therapeutically from lifestyle and nutritional options, meaning increase the protein intake, increase the vitamin supplementation, increase resistance training, and so on. Very briefly, some of the muscle preservation agents that was discussed. One is a myostatin, which is a natural protein that inhibits muscle growth. So anti-myostatin agents are being compared with GLP-GIP drugs. And some of other agents is bimagrumab, which is a monoclonal antibody that blocks activin, and several other candidates are coming down the line. So do remember strategies to prevent muscle loss when we use these medications that have changed obesity management in every country, but other issues such as muscle loss needs to be borne in mind, particularly in elderly population. Also, bone loss is another component to be monitored. Next generation obesity next generation obesity medication, we already talked about retatrutide. Pemvidutide is another one. Certain anabolic pharmaceuticals that seems to have repurposed, such as a SERM, and a new drug which is being investigated in Stanford is amlexonox. This is still being investigated in a rodent model at this point, but over a period of time, these might come up in your horizon. So key takeaways from ADA: superior weight loss drugs such as retatrutide seems to improve A1C and weight reduction. There's multiple other drugs that we just talked about that are coming up. So one needs to be aware of these medications. A combination of amylin and incretin drug, I think, is important to be considered for not just for diabetes, but for other associated insulin-resistant states, such as Alzheimer's and so on. And so there's a lot of new ideas and pathways being looked into from in metabolic disorder, as Einstein a long time back mentioned that it's a continual flight. So hopefully we have a lot of hope now than ever before, but it's a continuous process of discovery. And thank you, and I'm happy to take any questions.
Thank you so much, sir, for very detailed and covering all the present and future perspective of obesity care, and also covering the Western perspective of obesity management. We are planning to take questions and answer in the end, but let me ask you simple one question for the closer, that all the obesity medicine are reducing weight, but as a clinician, how we should explain our patient that what are the pleiotropic benefits, or whether we should explain them or not? How to proceed with
Now, of
that?
course, we should. I mean, that's one of the main reasons to use some of these agents. As I mentioned, that the focus have moved not just from weight management, but from a complication management. As I mentioned, some of the main complications being cardiorenal, MASLD, and so on. And I specifically showed some of these drugs. So I think one needs to explain that it's not just about weight management. As you know, some of the drugs, such as MASLD for resmetirom, has very little effect on weight, but has shown fibrosis reversal. So these addressing the complications is, I think, even more important, or sometimes as important as weight reduction in a care of obesity and associated diseases. Absolutely.
Thank you. Thank you so much, sir. So with that, let's move to the final talk of the symposium. That is a Middle East perspective of obesity. And for that, we have Dr. Mohamed Hassanein. Please share his CV slide. Sir is a professor of medicine, Mohammed bin Rashid University of Medicine and Health Science UAE, Associate Director, Postgraduate Diabetes Education, Cardiff University UK, Chair Diabetic and Ramadan International Alliance, co-author for International ADA, IDF, DAR, BMG and Diabetes Canada Ramadan Guidelines. Over 110 publications in national and international peer-reviewed journals, Associate Editor, Dubai Diabetes and Endocrinology Journal, and recipient of the Hamdan bin Rashid Al Makam Award for Medical Excellence in 2024. It's an honor and privilege to have you, sir.
Good morning, good evening, everyone. Many thanks for the invitation, and I have certainly enjoyed listening to the session so far. And let me share my slides. I'm going to address the Middle East perspective, primarily data from where I currently work in Dubai, which by virtue of the geographic or the structure of the country and the population of the country has a very fair number of people from different ethnic groups, certainly from Southeast Asia as well. So I think that has been already covered. You all know the very important impact of obesity on different major NCDs across many countries. So that has been covered. So specifically looking into the Middle East, you'd see from the World Obesity color coding that many of the countries are in the dark blue, which indicates it's above 30, and small number of countries in the Maghreb countries in North Africa, they are on the dark green, and which is 20 to 30%. So clearly, it is a problem that is really quite prevalent. As we are speaking, the World Cup is ongoing. And the ranking of this is the unfortunate ranking of many of the Middle East countries on the prevalence of obesity in adults. And as you can see, many of the Middle East countries are even higher than the US. And that's obviously, it's something that we need to try to improve on. So Gulf countries, Egypt, where I come from, and many other countries have very high prevalence of obesity. Now, the gender issue is quite an important one here. It does look like a reasonable percentage of women in the region have higher proportion of obesity in comparison to men, and men have higher proportion of overweight. And that's something also that we need to try to prevent. If I look into Gulf countries, Qatar, Saudi Arabia, Kuwait, are pretty high, and Egypt seems to be the highest as the lifestyle have changed into a very more sedentary lifestyle. Now, children, and in the previous questions and discussions, and the question of Purvi about children and women, so I've shown you here women, and here is the data on children. And it's really quite sad to see this. And even though that the Middle East have the mix of upper middle income, high income, or low income, regardless of the level of income, you can see that 8 out of the top 40 countries with obesity come in the Middle East, regardless of the level of income. So it is not just related to the income of the country, but perhaps the lifestyle. And let me have a deep dive into the data from UAE, as I have been privileged to be part of the household surveys that the Dubai Authority are doing, similar to the WHO standards. But first, we need to understand the population, because it's a very different population to the population where I was working in UK for 24 years, where mostly it's an elderly populations. Here, as you can see here, I want you to focus, for example, on seniors. 1.9% are 65 or above. The vast majority of the population are people from mid-teens to 64. And quite a sizable proportion, 14.5%, are young children. So if you were to narrow it a bit, the sort of age of 15 to 39 years, that's 54% of the population. Now, why did I focus on this group? Because this is the more younger adults who are presumably more active. And if they were to develop these NCDs like obesity and diabetes, then they will have the condition for many, many years. If I develop obesity when I'm 70, then it's a lot better than developing when I'm 40. Now, when we look into the data of Dubai that we've published a couple of years ago, and you look into how many are with a normal BMI, and of course, the BMI here is not so accurate because, as I mentioned, we have lots of people from Southeast Asia, and the BMI was not corrected for the ethnicity. So probably that 42% will be a bit lower, and consequently the overweight and obese figures would be a bit higher. But nevertheless, we are talking about 60% of the population are either overweight or obese. And you can see the serious issue of that normal in very young teenagers and 20s is only 65%. So a third of the population of young people are either overweight or obese. When we look into more recent data that we've collected from the register, from the electronic records, in Dubai we have electronic records for the Dubai Health, and this data was really quite massive, and we looked into children. So again, it's quite sad to see that 28.7% are either overweight or obese from the children who are attending Dubai Health Authority facilities for whatever reasons they are. And the split between in gender here wasn't really too much different. 47.8% were female and 52.2 were male, so kind of 50-50. And also it wasn't too much different between UAE nationals and other nationalities, as the data had 45% of them of UAE nationality. Now, when we look into the male-female gender and effect of this, as I've told you before, females tend to have a bit more obesity, but men tend to have more of the overweight. And certainly for both, there's a correlation with marriage. Not that I'm against marriage, but it does look like being single has a better impact on weight. 25.8% were overweight, or 63% were normal weight with when they are single, and that massively dropped to only 33% or 33.8%. And that's, as you can see, for both men and women. Well, I understand it for women because obviously the pregnancies and the impact of it on the weight of the women, but I'm not really sure why is it different for men as well. Maybe it's the kind of sharing for the wrong reasons. So it's really quite important to understand the population. And when I look into the Gulf countries and the Middle East, perhaps that would also reflect on India, on the change that happens over the last 50 years. With the westernization and the industrialization of many of the cities, this is Dubai 50 years ago, and this is Dubai now. So with that change came obesity and diabetes and hypertension and cardiovascular disease, because the rapid wealth and economy have led also to a massive increase in refined carbs, which led to the biochemical changes that leads to dysglycemia, hypertension, dyslipidemia. And obviously with the sedentary lifestyle, when people are hardly doing physical activity now, then that leads to obesity and diabetes across close to each other. So looking into what do we eat now? So the question is why? And when you look into from the survey that we did with the Ministry of Health and Prevention, when you look into eating 5 servings of fruits or veg, this is obviously what's recommended in many countries. And I can tell you the supermarkets are full of the different types of food across all seasons. You will not be short of a melon even in the middle of winter. But unfortunately, 82% of the population, whether they are men or women, whether they are Emirati or non-Emirati, they are not having the 5 servings a day of fruits or vegetables. Now, we know that Arabs are pretty generous, and the classic food is a base of lots of rice and meat and other stuff. But now we are also struggling with the competition of the mostly American style of fast food, which is competing to make people eating more and more of the wrong type of food on a frequent level. Now, when that is coupled across the Middle East with low level of physical activity, this is a study that we conducted asking people of their level of physical activity. And normally people would exaggerate to say they are more active. So unfortunately, as you can see here, about 64% are saying they are either inactive or with low level of activity. When we look specifically in Dubai household survey, and we ask people whether they're spending 10 minutes only during the moderate physical activity, during routine work or routine housework, who is doing that on a daily basis? And only 17% are doing 10 minutes on a daily basis. Now, when we asked a bit more of the vigorous level of activity, and by all means it's not vigorous at all, it's only 10 minutes of running or playing football on a daily basis, and that is done by 5% of the population. Although, as I've told you, if you remember, the vast majority of the population are young. 1.9% are those above the age of 65. So that really describes what is happening. And then when you look into the obesity in Dubai based on nationality, it does look like it's the culture, it's the style. So UAE and Arabs share more or less the identical picture, maybe slight difference between overweight and obesity. So about only 30% of them have normal weight. But when you look into Western society, it's 43%. And I'm not surprised. When I used to work in UK and we meet on a Monday morning, ask my friends who are from Asian or Arab background, what did you do for the weekend? It's usually we had a barbecue or we had a nice meal at someone's house. When I ask my English friends, it was usually we went walking or climbing or playing something. So the physical activity and the culture is really quite important. In this slide, I tried to show you the impact of a number of factors: the region, the gender, and the income. So we have, for example, Egypt, which is considered as low to middle income. You have Algeria, which is considered as upper middle income. And you have Saudi Arabia, which is considered as high income. And here we have the figures of obesity based on gender, whether it's males or females, and obviously all adults. And as you can see, regardless of the level of income, they're all with the same sort of configuration, whether it's in Egypt or in Saudi Arabia or Algeria. The problem is more or less the same, which confirms what I feel personally. It's not about the level of economy, it's what you do in your routine life. And of course, obesity has a massive burden. When I look into the impact of BMI on the different NCDs. And I here highlighted with the arrows the regions that are more related. So Southeast Asia in gray, and Mediterranean countries in East Mediterranean countries is red. And we are among the highest when it comes to diabetes, chronic heart disease, coronary heart disease, for the impact on NCDs relation to obesity. Now, when we reflected on the data from the Dubai Household Survey and looked into prediabetes in people with normal BMI, regardless of the nationality, look into the green, everyone living in Dubai, it was 7%. But when you see it in the overweight, it jumps to 25. And if you were to ask why it goes lower in the obese of 16%, because the majority of them develop diabetes rather than prediabetes. So clearly, there's a very clear correlation between obesity and developing other condition, metabolic condition, such as diabetes. And the sad scenario that this is increasing by high rates in adults and in children on an annual basis, 1.5% to 2.5%. So if you were to think about it in 10 years, that would mean over 15 to 25% increase in the level of obesities if nothing is being done. And again, the correlation is related to the physical activity. People who are physically active have 9.9% prevalence of diabetes. People who are not active, they have 25%. So 2.5 times, double the prevalence based on level of activity. So really, it's quite a serious issue. And the same applies to the BMI, normal BMI, overweight and obese from the data of household surveys that we've done here. And these slides include both of them together. So of course, the GLP-1s and the other medication are a very effective drug, but they don't treat the cause. They don't treat the root of the problem. And it's very important that as we put any guidelines, and I have been involved in some guidelines, and we're not short of guidelines, but we're short of implementation of the guidelines. And the number one point of the implementation of the guidelines is treating the cause of the problem. And as I've shown you from our data, the cause of the problem is not the genetics, because the same genetics was there 50 years ago. It's the change in lifestyle, in physical activity, as well as in what we eat. So here is the importance of doing something. This is a study from Algeria looking into the prevalence over the years. And again, it's increasing. So we need to try to do something. And by doing something, I don't necessarily mean having these beautiful buildings. I work in Dubai Health, and this is our outpatient department. This is Cleveland Clinic, and this is Imperial College in Abu Dhabi. And all of these, obviously, fantastic buildings, as well as the availability of the expensive drugs, is very important. I do not deny that. It's fantastic to have these facilities, which obviously cost a lot of huge amount of money. But the number one point in any clinical guidelines, and I've been privileged to be part of the EE guidelines that was published a year ago, is the physical activity and the change in diet. And that's very clearly illustrated in all guidelines. We are not unique in the UE guidelines to state the different types of physical activity that people can engage in, whether the weather is hot or not, and the facilities are there. When we ask people in UAE, are the facilities available? Availability of public parks near my residence, over 60%, whether they are Emirati or non-Emirati, say yes. Availability close to the working place during physical working hours, and over 20% are saying yes. Sidewalks near across the road, maybe this is something that we need to improve on. So it's not about the availability. As you can see, these are pictures from Dubai, and the availability is remarkable. But I want you to look deeper into this picture. Do you see any people in these pictures? Very small number of people. So the government have made lots of places available, but we need to encourage people and change the culture. How do we encourage people? One of these initiatives is really key. This is the Crown Prince of Dubai, and he has set up this fitness challenge of 30 by 30, which means for 30 consecutive days, 30 minutes of physical activity across many places. And it has encouraged indeed some people, as you can see, that physical activity over the last 10 years have slightly increased. But what has not improved is the type of food that we eat. So consequently, obesity has not been halted yet. This is data before the abundance of availability of the powerful GLP-1s for the treatment of obesity. Maybe it has flattened, but that is something that we need to look into. So, ladies and gentlemen, conclusion. The prevalence of obesity in the Middle East is alarming. And it obviously matches what you have in India, America, and many other countries. It is very strongly related to age, female gender, eating less fruits and veg, and physical inactivity. We need urgent structured plans that can address the large scale of the problem. And this really is quite overdue because obviously we need to hold the serious health issues. Certainly better eating habits and improved level of physical activity appears to be keen alongside, of course, the availability of the drugs that can improve obesity and its outcomes. Thank you, and I look forward to taking part in the Q&A session.
Thank you. Thank you so much, Professor Mohamed Hassanein, sir, for a very detailed and insightful talk. You have covered the gaps from not only clinician or government side, but public has to be involved, and their participation is in must for the management and prevention of obesity. I would take one question from you, and then we'll move on to the panel discussion. My dear friend, Senior Dr. Vinod sir asked question that if you could implement just one global intervention over the next decade, whether it may be policy based, technological based, pharmacological based, or even societal thing, which do you believe would be the greatest impact on reversing the epidemic of obesity?
Structured education for obesity that is available on digital platforms. Many of us don't even know the carbs and the calorie contents of many food, even though that we are qualified clinicians that treat people. So if we don't know the exact difference between having 3 dates and having an apple, how can we ask people with diabetes or obesity to understand what they're eating? And doing it on a one-to-one basis is not enough. It needs something that would be smart and reaches the millions and millions people out so that at least they are aware and conscious of what's the impact of what they eat and what they drink and what they do in a simple way. And then at least they wouldn't say, well, nobody told me. I think we need to, because we owe it to the young people and to the younger generations so that we can stop the problem for the long term.
Very perfectly answered, sir. I totally agree with you. Let's move to the panel discussion. But before that, I would like to ask Dr. Banshi, sir. There were 3 wonderful talks, sir. Any remark from your side on this execution of an idea of Impact 365?
One is that more than 2,000 delegates who joined, participants, that itself is a very impactful, this meeting is with 360 degree, which we are saying. Thank you once again to Victoria and particularly Sabi, because they are joining late in evening from USA. And a wonderful talk by Dr. Mohamed, and he has shown the Middle East perspective. We can have panel discussion because I'm worried that it will be very late for Dr. Victoria and Dr. Sebi. So you introduce Dr. Makkar.
So moderator of this panel discussion is Dr. B.M. Makkar, sir. Please load his slides, sir. He's a director at Dr. Makkar's Diabetes and
Vipul,
Obesity
we
Care
can
Center.
skip the introduction. Everyone knows
No, but
the
internationally people should know,
Okay.
There is a national president for our Aero Society, immediate past president for RSSDI, and a member for AACs and ACE Professional Business Committee. Also, course director for Advanced Certificate Course in Diabetes, that is ACCD, in collaboration with Cleveland Clinic and ESD since 2010, and multiple awards and oration and multiple chapters in book in national and international journals. So, sir is our moderator for this panel. Dr. Sasank Joshi, sir, is a panelist, MD, DM, FICP, FICN, FRCP, multiple leadership role, multiple presidencies in his accolade, founder and executing roles in multiple societies. And his involvement in academic and professional thing is excellent. And he's a leader for many people like me. Then Dr. Purvi Chawla, ma'am, who is a consultant diabetologist at VLSR, the clinic Bharatiya Arogya Nidhi Hospital, Nanavati Max Super Speciality Hospital, and BSES Global Hospital in Mumbai. Currently, she is an Secretary General for Aero Society of India, a co-and sub-investigator for many global and national trials. She is also a secretary for IDF Women and Diabetes Group and chair for Diabetes and Women Interest Group, Diabetes in India, and many positions at multiple prestigious places. And also, the last panelist is Dr. Amit Gupta, sir, who is a director, Center for Diabetes Care, Greater Noida, adjunct professor, Department of Medicine, KMC, Manipal, and Mahe, chair, IDF School of Diabetes, chair elect, ADA, Public Health and Epidemiological Interest Group, honorary secretary for International Advisory Board of ADA, and executive council member for RSSDI in 2022 to 2025, and multiple other achievements in his CV. So, without wasting much time, let's move on to the panel discussion. And I would request Dr. B.M. Makkar, sir, to start the panel discussion.
Thank you, Vipul, for a very kind introduction. It's indeed a great pleasure to be among stalwarts in the field of diabetes and obesity medicine. And I am sure you will all will agree that we have three fantastic presentations looking at different aspects and different perspective about, obesity as a challenge and not only a challenge in terms of disease, but also how to take on this challenge and how to, manage it. And some of the key points that came up very nicely is one is that we still need to do a lot of work on recognizing obesity as a disease, as a chronic relapsing disease. And there, I think everyone agrees, especially, the highlights from Victoria's talk and again from Mohammed's, reply to your quick question, that structured education, which is available to all and is available on digital platforms so that there is huge, access to that same information is going to play a major role in improving the obesity challenge that we are facing today. So, with on that note, I don't see any questions coming in the chat box. Vipul, you are getting the questions in chat box?
Sir, I have WhatsApp you personally, sir.
Okay, give me a second.
Dr. Makkar, can I comment on your point?
Sure. Yeah, sure. Absolutely.
Before the powerful GLP-1s, we struggled to convince people about obesity. But
Yes.
nowadays it's the opposite. They are coming to clinic to request the treatment. And in some circumstances, they are getting the treatment regardless of even a prescription. So the problem is the recognition of obesity is for the image and not for the health. So currently people are asking for treatment to look slimmer and not to improve the concerns of health. So it's an opportunity that we need to, as the public nowadays are conscious about, there is treatment of obesity, I can look better. It's also to make them maybe use a campaign to make them understand you're not just going to look better, but you will stop and prevent many of the health issues. So the recognition of obesity as a chronic disease, maybe this was something that was there 10 years ago and beyond, but currently it's very much in the mind of people, but perhaps not for the main reason of why we want to treat obesity. That's my
I,
personal opinion. I don't know what's Victoria's opinion on this.
Yes,
Yeah,
Victoria, we can have quick remarks from you.
yeah, I think multiple things can be true, and I think it varies based on the regions. Unfortunately, there are places that is not recognized as a disease. We are having some challenges even here in the States where certain places, certain reimbursement areas don't recognize it. Certain countries don't recognize it. So I think that not necessarily. I think both are true. That it just depends on where you are and the countries and what exactly they're dealing with.
I think, it's a very important point again, because there are so many, there is so much of cultural diversity and diversity of thought process and perceptions and perspectives that, every country, every region turns out to be different. And Mohammed, your remark was very right, that most of the people are not actually coming up for treatment of obesity, considering this as a disease. Still, they are talking about slimming. And a lot of it has the background in, stigmatization, because they have been stigmatized for that, appearance or shape. I think that has a lot to blame on that front. But another important thing is, with the availability of these molecules, you rightly said that some of the people are getting it without even prescription. So in India, situation is pretty bad on that note. If you look at the total prescription market, it is only about a third of the total sales of GLP-1 based therapies. And now we have generic versions here, which is easily available. The one of the challenges that has happened recently is that even the healthcare providers, they were not geared to treat obesity, because we didn't have much medication. People have not been trained or kind of, orientated towards obesity management in clinics as a dedicated area of disease management. So even the in the clinics, you don't have, something very simple like privacy for measuring weight or privacy for discussing the problem with patient, and patients are not even you have the adequate, space for their sitting. When a person with obesity walks into a clinic, most of the time, if you see in the waiting area, they keep standing, because they are always afraid that if they sit on the regular chair, it might break, and that's why they don't want to sit on the chair. So there are so many things which need to be corrected, and I am sure all these things are going to improve now, because there is a lot of noise because of the introduction of newer therapies. So let's start from Victoria's talk. Victoria, you did a wonderful presentation on based on the recent recommendations from Obesity Association and obesity management, standards of care. Uh, where do you see the role of these standards of care getting adapted at primary care level in US?
Yeah, that's a good question. And I think that's very important. I emphasize implementation. I know Dr. Mohammed also emphasized implementation. And I always say that, the science is very important to me, write these guidelines, etc. I really think, number one, it has to be individualized to the clinic and also the system level. We should really utilize the resources we have around us. There has to be intentionality in terms of when it comes to anthropometric measures, for example, who in the clinic can do it. It doesn't have to be the the person who's actually seeing the patients, the doctor, the practicing provider. It can be the medical staff that's been trained. So within the clinic, I think there just should be a workflow and a process for optimization. BMI is always still going to be the screen. but there should be standardization as to if the screen is positive, that next step should be something that is standardized and optimized within the clinic. And that would change based on what the clinic looks like, the resources that are around you regarding your particular setting.
So another, important parameter you highlighted that in association with BMI, we should look at central obesity. And I am sure Mohammad will agree, measuring a waist circumference in so many countries and the populations because of cultural reasons become a big challenge. And, ideally, you should be measuring waist circumference directly on skin. But you can't tell, particularly the women, to kind of bare their abdominal area to measure waist circumference. And that becomes a very big challenge for measuring waist circumference, which is an important marker for central obesity in our countries. Mohammed, you want to comment on that? How do
Yeah,
you tackle this?
I think it is an issue. Although, I mean, in many places, the setup is the patient will have their weight and blood pressure and stuff like this done by the nurse before entering the doctor's room. And that's a private place. So and it's usually gender oriented. So female patients with a female nurse, male patients with the male nurse. But it's the inconvenience as well as the difficulties, especially in obesity. If you try to find exactly where is the marker and where's the bone and to do it, it's not an easy test. And I agree with you, Makkar, that it is culturally a bit insensitive. But there are ways, and if we are talking about investment in the service, having the fancy tools to measure the lean body mass and so forth are not too expensive for a busy clinic that will give patients, and patients love it when they come and say, doctor, my water percentage or my fat percentage have changed from that much to that much, and it's a much more accurate than simply, because I also have many patients say to me, doctor, my weight is because I have heavy bones, which
Yeah,
I still don't really know what does this scientifically means.
I agree. I
I probably
totally
have
agree.
heavy bones as well, which is the cause of my overweight.
No, I for sure have heavy bones. So that's the situation everywhere. So I would now request Amit to respond to this. We have Indian data now looking at the prevalence of obesity as a major challenge, especially from ICMR in-depth publication. Now National Family Health Survey, giving you the fresh figures. Looking at the figures, we are having almost 30 to 40% population, adult population, affected by obesity and overweight. And with the kind of numbers that we are looking at, what do you think, about the preparedness of the healthcare profession to tackle such a challenge, and what should be the, intervention that one most effective intervention that we should look at?
I think Makkar sir, this is very, very important because as we discussed earlier that India and some of the other Asian countries are at a, you can say, at a point where either you can change the curve or the trajectory, or otherwise it is going to explode like anything. And the collaboration is a way forward. And as Dr. Mohamed Hassanein pointed out, the first responsibility of healthcare professionals should be that avoiding their clinics turning into a slimming clinic. So our conversation should be focused more on the obesity as a health issue, not obesity as a slimming issue. While the other sectors like the beauty clinics, slimming clinics, gyms and all, they are not promoting it as a healthy or a health component. They're promoting it as a slimming component. So I think our focus should be on more and more on education, as Victoria also said, education of the healthcare professionals, and bringing some simple important tools. And so when we know that there is a difficulty and we are culturally sensitive, so probably we can look beyond waist circumference also. And we have to devise our own ways that how do we even cater to this population, because this is going to be a big challenge. You can't change the culture overnight, and you can't change the clinical settings overnight as well. So maybe sometimes devising simple tools, more education programs for the clinics as well as for the patient. This is going to be the way forward, sir.
Thank you. Over to Purvi. Purvi is currently the secretary of our Indian Obesity Society called ARO, Association for Advancing Research in Obesity. So Purvi, uh, now we are actively working in the Obesity Society. What are the challenges you feel that you are muted? So what are the current challenges that you see that we are getting to spread the message that everybody should be screened for obesity?
Great question, Dr. Makkar sir, and thank you for this opportunity. I should say a big thanks to Dr. Banshi sir also for this opportunity to be with all of you here Sunday morning chiming in. So I think one of the biggest barriers is lack of acceptance. And the other simultaneous one is the bias and stigma against obesity. Um, I think the awareness can be broken, right? I just wanted to add to, a couple of points to what Amit already very well elaborated on. I think we need to start at the medical college level. Our curriculum does not, uh, include much of obesity care at all. In fact, leave alone diagnosis or, management, it just barely talks about obesity and its ill effects. So we need to start right from there, plus have, our primary care also very, very well aware and in sync with the entire aspect of dealing with obesity, because again, in India, primary care is very important. Even when physicians are going to prescribe drugs, it is the primary care physician who's going to be asked first, because people trust them the most, and they have that first interface with the patient. So they are going to be asked, whether the drugs are safe, whether what they have been given is all right or not to take, so on and so forth. So that awareness is also very important. And I think one basic aspect is that we need to fine tune the education models to modules or models to individualize our, and suit our sort of social and cultural milieu. Because again, we just cannot adapt what is already existing for the Western world, just simply, run that in India. We need to develop our own modules which are culturally sensitive, which probably are in the local language as well, and they speak to the exact problem that we face. And that, I think, will make a massive difference. And we all seem to agree that education and awareness is the way forward. I think that also will help us to address the bias and stigma against it.
I think an important point, and thank you for that. I am sure this should be the last question to Victoria. It's close to 1 a.m. in her region. So Victoria, last question. I know you must be very sleepy by now, but fortunately tomorrow is Sunday morning, so you can get up late. So do you think the numbers of people living with obesity that we are going to handle in the current scenario, do we need primary care to be strengthened to manage obesity? Because I don't think any country or any region has the capacity of specialists to tackle these kind of numbers. And if we have to do that, again, what should be the one key intervention that strengthens the primary care in managing obesity?
Yeah, I would just have to piggyback on what Dr. Purvi just mentioned, when it comes to the empowerment of primary care. For the most part, primary care globally is the place where people go first. So when it comes to the recognition, when it comes to screening and diagnosis, when it comes to the counseling and treatment of obesity, that is where I think we really have to have concerted efforts. And as you noted perfectly, there aren't enough specialists globally in order to tackle this epidemic. So we have to make sure that, as it has been mentioned before, that there's strengthening in the education for that first stop that people tend to go to whenever they seek care.
Thank you. I think we are, we are comfortably placed in India, but in US and other regions, it's past midnight. So I would now
No,
come to
but
the close
before
of
she
the
leaves,
session. No, I'm going to hand over to Banshi only for final,
no,
closing.
not final. That,
Okay.
before she leaves, you may continue the panel discussion, because Dr. Hassanein made a very beautiful remark that people wanted to go to doctor's clinic for slimming, for their weight reduction.
Yes.
That's not the health is not the primary criteria for them. And healthcare professional wants to show that obesity is a condition which is a problem of related to multiple health issues which are there. Why can't we bridge this gap that people want to slim and we want to give them a good health care? I mean, 50% of our population going to slimming center, which are actually not the official healthcare professional, sorry, and they are even writing prescription also in India. As Makkar had in his opening remarks, he talked that 50% of prescriptions of GLP-1 in India are over the counter, or they are getting through the slimming center. So can't we do some bridging the gap between the people who wants to look slim, they want to look beautiful, and that's the reason why they want to take the treatment, and other side, we association, whether it's any obesity or diabetes or any metabolic association, wants to treat them, because we understand that obesity is a unhealthy condition which leads to a lot of complications. So can't we bridge the gap? And that's the reason that globally, can't we do something which will provide care for these people who wants to look slim, and they want to, and healthcare professional wants to give them a better healthcare? Comment from both of you, and then from Indian perspective also.
Yeah, I agree with you, Banshi, and this is what I mentioned. It's an opportunity. In the past, the public was not interested. Now they are interested for whatever the reason. So perhaps if we can make the link stronger between losing weight and improving health, specifically the things that can be directly measured, blood pressure, glycemic levels. These are numerical things that people will be able to see. After 3 months, my blood pressure has changed from that to that, my glucose levels or HbA1c or whatever. So it's important that we start to focus on these links so that it helps and motivate people to continue with their program, whatever program they're doing. And also understand, because many are taking the injection and just waiting for the effect of the injection. But they also need to understand the impact of the physical activity and the choices of foods, so they can enhance the effect of the treatment they are taking. And that probably is information and behavior change that will last with them beyond the injection. Because we know the injections prescribing in this group is off on. It's not sustained all the time.
Yeah, and I completely agree with Dr. Mohamed. And the additional comment I would make is it emphasizes the point I was making about the recognition of this being a disease, because it's viewed cosmetically. You're seeing some of this, entering of whatever access I can get in order for it to be a cosmetic result. But if we truly say that and emphasize and there's awareness that this is a disease, then it becomes not just an injection, but a holistic approach to the treatment, recognizing that it's just not an injection, but you need quality and safety when it comes to the monitoring of the treatment. So again, it goes back to the recognition that if you're treating anything else, you're going to want to look at experts. You're going to want to make sure that the source and who is treating you are actually people who know what they're doing because of your safety and because to make sure that long-term effects are seen in this chronic disease.
Sir, I would like to highlight one important thing which we discussed about the primary care. And this is a system level problem, you can say, because in the countries where the primary care is well defined and there are structured pathways for the referrals, the primary care ends up being strengthened. But in a country like India, where there is no structured pathway for referrals and all, and so the primary care system is actually weakened here. And because of that reason, the primary care professionals, they are not looked upon as someone who can provide the obesity care or the diabetes care. They are looked upon as a doctor who can simply treat common cold, flu, and fever. And this gap is increasing. And I think primary care should not be looked as an elementary care or the basic care. I think how do we go about it and how to change that so that the primary care, they feel empowered, they feel strengthened and not just marginalized in a system where there is no structured pathway.
So I think, Amit, you have a point, and why I wanted to raise that point was again to highlight that this is one area which needs to be looked up, and whenever there is a gap, it also creates an opportunity to work and improve things. So I think if you look at the numbers of people living with diabetes or obesity, the recognition and care has to begin at primary care level. And this is one area which needs to be strengthened. And all the guidelines that we come up and, we think that guidelines are directed for physicians or specialists. Actually, most of them are already, using the practice standards that are there. It is the primary care people who need some education about guidelines or very practical, short, flow diet charts, I would say, which can guide them to, say, steer carefully among the diseases that they are not used to treating. So if we create some very simple, recommendations for primary care level, how to recognize obesity and how to initiate discussion or treatment of obesity, I think it is going to go a long way in managing the kind of challenge that we are looking at. So primary care has to be strengthened by all means to tackle these diseases. I'm sure Victoria and Mohamed will also agree on this. We can't do all these diseases tackled by only specialists. Now, another important area is, Banshi highlighted very nicely that people let them come for slimming, but we can connect that to, obesity as a disease, and we can take this again a challenge as an opportunity to educate these people and engage them on long-term management. So these are the areas that need to be, again looked at as important interventions. So, Mohammed, you showed very nicely, and I was
Sabya sir and
amazed.
Purvi ma'am has raised their hand. I think they want to add something here.
Okay.
So very quickly, I think I want to belabor on the point that, we as physicians also need to emphasize on the lifestyle modification aspect of it. And just anti-obesity medication prescription is not enough. Yes, we are learning to tackle the nutritional aspect with GLP-1 because that's being talked about. But I think the underlying message of increasing physical activity and in a very structured manner, along with reading food labels and making the right choices is equally important. And another aspect is treating the entire family. It's a philosophy around obesity management. It's not just treating, one patient, it's the entire household that comes into the picture. So I think these are some aspects that we, again, as physicians, we need to highlight that and adopt that in our community first before we reach out to the others.
Very important points. Actually, I was trying to raise the same point with Mohammed. Mohammed showed very interesting data. Sabya, I'll come to you next after this. So you showed very interesting data that people are doing, the household work only about 12 minutes a day or something
10.
like that. And if you ask them how much time they are walking, again, it's few minutes a day. It's not even half an hour. Now, despite availability of all the facilities in your, country where you are practicing, how do you tackle this? This is the mindset and the behavior issue. It is not just availability of facilities and, your awareness about health.
I think we need to sustain the good initiatives and think of a multidisciplinary approach from media, from key people in the country, celebrities or authorities, raise the availability of these places. Dubai is a pure example of how behavior change has happened. When you go and walk in the beach on Dubai, you can see someone in bikini and someone in the traditional covered dress. That is something that is terribly tolerated, no problem. So the behavior of the people to adopt and accommodate people of different style of culture is there. Then we need to take that to ourselves. What has changed in our food? As a Mediterranean person from Egypt, our food in the past used to be on a daily basis, there is vegetables and salads. Now it has moved to the fried chicken and the burgers and the fries. I never had in my country a sandwich of fries. Now people are going to buy a sandwich of fries. So bread and fries. So the culture is changing, and we need to try to reverse this by giving the good examples. Instead of the family gathering to be simply, or friends gathering to be simply in a place to eat and chat, why isn't it possibly on the park or on the beach and we can still have the chat? So try to stimulate some of the behavior change to address the root of the problem. Kids nowadays in the region have their own phone and they are ordering the delivery. They are refusing the mother's food and they're ordering their own delivery food. So it needs to start to change gradually, because this process in the future will become as a very serious epidemic. So we're not going to be short of work, but on a more serious note, it's really something that needs to be addressed at the
I
root.
know. I know it's a serious challenge. Yeah, Sabyasachi, you wanted to comment.
Yeah, so I think what Bangchi just mentioned, that we need to incorporate the patients who are seeking medications from other sources. It's obvious that those patients have realized, for cosmetic reasons or otherwise, that their obesity needs to be treated. Are we failing that population? Are we turning them away? Is there a lack of confidence in physicians and otherwise to prescribe, monitor, and supplement our treatment with other modalities? For example, it needs to be, as Dr. Mohamed just mentioned, this needs to be a multidisciplinary approach. Is our approach not correct? Are we giving them information about cardiorenal and metabolic disorders? Are we giving them information about so-called liver diseases and so on? Maybe we are not implementing or have the time to tell them that this is a multidisciplinary disease and you need to be more confident about treating all of these conditions either at the same time or individually, and have a dietitian involved, have a fibroscan involved. I think the multidisciplinary approach is missing, and we are essentially losing our patients to a non-medical institution. And before this becomes a major problem in our practice, I think we need to be more confident in how we approach our patients and not say that, you know what, it's not my problem, it's primary care's problem, or primary care's problem, not mine. We are all involved somehow. So I think we need to be more confident. I mean, this is not just about adult medicine, right? This is more about even pediatricians. Are pediatricians incorporating these medications and other modalities together so that we don't have such a major pediatric obesity problem? So I think we need to look at ourselves as well while we look at other modalities and other groups of physicians as well. Just a comment.
I think a very important comment. Purvi, you again have your raise hand. Yeah.
Again, so very quickly, I think that just boils down to acceptance, because I think most people would think that, if they're clinically all right based on, just symptoms, they feel that, they are medicalizing something that just requires mild reduction or, change in the appearance. So I think, again, that comes down to education and awareness. The more we work at it at different levels, I think we can do it.
Yeah, I think this is important. And just to, let you all know that we are already having a global obesity project at ADA Obesity Association, which is looking at more or less global aspect of interventions to tackle this challenge of obesity. And Victoria is heading that initiative, the Global Obesity Project. And fortunately, we are member of that project. I think it is 1 a.m. in your zone, Victoria. Am I correct?
You should
Yes,
close
it's
now.
1
You
a.m.
should close now.
So I think it is high time that we say good morning to you once again. And we come to close of this, session. I think this was a wonderful webinar, and all the attendees who were there must have benefited. Big round of applause to all the speakers here and all the panelists. And over to Banshi for vote of thanks.
Thank you, Dr. Makkar, for nicely moderating this wonderful session. I'm thanking Dr. Victoria, Dr. Mohamed Hassanein, and Dr. Sabyasachi Sen for this wonderful presentation which they have made. We learned a lot from ADA. I mean, it's a one session which we could do. It's not possible because decoding ADA means there are hundred of sessions, and even when we were there, we could not attend every session what they were. But still, we keep on doing. Yesterday night also, we were having session with our ADA president. What we learned, what was new in American Diabetic Association 2026 guideline. So a lot of things to learn, and we will keep on doing many more meetings. And thank you, Victoria, for this continuous collaboration. Thank you, Mohamed, for your always support, which you are always there. And our own Dr. Sebi, you are always there for us anytime. I mean, midnight, it's still late night, but you are there. So we are very much thankful. Thank you, Dr. Purvi. Thank you, Dr. Amit. Shashank could not join. He was in a flight and his flight got delayed. Thank you, Vipul, for coordinating this wonderful event. Thank you, Mr. Chopra, who was from organizing it along with Lupin. And once again, good day to everyone and good night for Sen and Dr. Victoria. Thank you.
Thank you.
Thank you so
Have
much.
a good time.
Bye, everyone.
Thank you very much.
Have
Thank
a
you.
great Sunday.